Welcome to Medical Specialists Associates educational series on topics in anesthesiology and critical care medicine. I'm Christopher Voss, MD, MS, FCCP, board certified in anesthesiology, critical care medicine, and neurocritical care medicine. Today we'll discuss when and how to use specific induction medications or combinations of medications based on clinical scenarios. We'll also cover the advantages of each drug and key considerations for managing potential complications. 1. Propofol. Clinical scenario. Ideal for hemodynamically stable patients undergoing elective surgery. Advantages. Rapid onset and short duration of action. Smooth induction and maintenance. Antiemetic properties reduce post-op nausea and vomiting. Potential complications. Hypotension. Be cautious in patients with cardiovascular compromise. Will induce apnea quickly, so assessment and preparation for difficult airways needs to be performed carefully before induction. Management tips: consider preloading with fluids or vasopressors to counteract hypotension. 2. Etomidate. Clinical scenario: excellent for patients with cardiovascular instability, such as trauma or shock. Advantages: minimal cardiovascular depression. A good option for patients with limited cardiac reserve. Potential complications. Adrenal suppression can inhibit cortisol production, requiring caution for prolonged intubation. Myoclonus may cause muscle twitching, although usually benign. Management tips: co-administer with an opioid to minimize myoclonus. Use cautiously in critically ill patients to avoid adrenal suppression. 3. Ketamine. Clinical scenario: ideal for trauma, asthma patients, or shock where hemodynamic stability is key. Neurological use. In neurocritical care, ketamine is used to lower ICP, making it a good choice in neurotrauma or cases of high ICP. Advantages: hemodynamic stability, increases heart rate and blood pressure. Bronchodilation, useful in patients with reactive airway diseases. Analgesia, provides excellent pain relief, particularly in trauma cases. Spontaneous breathing, maintains respiratory drive even at induction doses. Potential complications. Emergence delirium, can cause vivid dreams or hallucinations during recovery. Increased ICP. This was previously a concern but has been largely disproven in current neurocritical care practices. Excess salivation. Ketamine can cause excessive salivation, which can be mitigated by using an antimuscarinic agent like glycopyrrolate or pairing it with Precedex or a benzodiazepine. Management tips: consider co-administration with benzodiazepines to reduce emergence reactions. Use in neurocritical care to help lower ICP in certain conditions, like traumatic brain injury. Use an antimuscarinic or pair with Precedex or a benzodiazepine to manage excessive salivation. 4. High-dose opioids clinical scenario. Effective for cardiac and neurological inductions, particularly where maintaining hemodynamic stability or controlling ICP is crucial. Advantages: cardiac surgery. High doses of opioids, fentanyl, provide excellent cardiovascular stability. Neurological surgery. High-dose opioids help reduce sympathetic response and control ICP, making them useful in neurosurgical patients. Potential complications. Respiratory depression. High doses can cause significant respiratory depression. Bradycardia. High doses may also cause bradycardia and hypotension. Acute chest wall rigidity. High-dose opioids can cause acute chest wall rigidity, making ventilation difficult. Management tips: titrate doses carefully based on patient condition. Be prepared with respiratory support during and after induction. Consider using muscle relaxants if chest wall rigidity occurs. 5. Thiopental barbiturates. Clinical scenario. Useful in status epilepticus or cases requiring rapid deep sedation, though less commonly used. Advantages: rapid onset, suitable for emergency situations, provides neuroprotection by reducing intracranial pressure. Potential complications. Cardiovascular depression, can cause significant hypotension. Prolonged sedation. Recovery can be slow with repeated doses. Management tips: avoid in patients with significant cardiovascular compromise. Careful titration is required, particularly in the elderly. 6. Precedex. Clinical scenario. Ideal for sedation without respiratory depression, especially in awake spontaneous breathing inductions. Advantages: sedation without suppressing respiratory drive. Provides analgesia and anxiety management. Potential complications: bradycardia and hypotension. Monitor heart rate and blood pressure closely. Delayed onset, slower onset than other induction agents. Management tips: administer slowly to prevent significant bradycardia or hypotension. Consider combining with ketamine for awake intubation to maintain spontaneous breathing. 7. Lidocaine. Clinical scenario: often used as an adjunct to reduce airway irritation and blunt the sympathetic response to laryngoscopy and intubation. Advantages: reduces airway reactivity, blunts the sympathetic response, lowering heart rate and blood pressure during intubation. Potential complications: toxicity. High doses can cause cardiovascular or CNS toxicity. Local irritation may cause mild discomfort at the injection site. Management tips: use weight-based dosing to avoid toxicity. Administer 1 to 2 minutes before intubation to allow optimal effect. Combination approaches: 1. Propofol plus opioid. Provides smoother induction with reduced doses of each agent. 2. Ketamine plus propofol, ketofol. Combines ketamine's hemodynamic stability with the smooth sedation of propofol. 3. Ketamine plus Precedex. Effective for awake intubations. Maintaining sedation while preserving spontaneous breathing. Management tips: monitor for respiratory depression and hemodynamic changes, particularly in high-risk patients. Adjust doses based on patient condition and the specific surgical procedure. Induction methods. 1. Regular intubation. Standard approach for hemodynamically stable patients. Use agents like propofol or etomidate combined with opioids. 2. Rapid sequence induction. Ideal for high-risk aspiration patients. Use of etomidate or ketamine combined with a rapid onset muscle relaxant like succinylcholine or rocuronium. 3. Awake spontaneous breathing intubation. Best for patients where airway management is difficult, but spontaneous breathing needs to be preserved. Combination of ketamine plus Precedex is effective in these cases, allowing the patient to maintain respiratory drive while sedated. Choosing the right induction agent and method is critical for anesthesia and critical care management. Tailor your drug selection based on the patient's clinical condition, procedure, and specific needs. Being prepared to manage complications will help ensure the best outcomes. To learn more about anesthesiology and critical care medicine, please visit us on our website at medspecialists.net and subscribe to our YouTube channel.